A macular hole is a full thickness defect at the center of the retina. Unless treated appropriately, it can lead to progressive loss of vision. Treatment of a macular hole depends on three criteria. First, the cause of the macular hole. Though majority of macular holes are idiopathic or primary, however, a macular hole can also be secondary to trauma, myopia, or diabetes. The second important criteria is the status of vitreous, whether vitreomacular traction is present or absent. The third criteria is the aperture size of the hole. This is the narrowest hole width in mid-retina measured by OCT's caliper function. Based on aperture size, macular holes are further subclassified as small macular hole. These can close spontaneously or even with non-surgical approaches. In this case of a small macular hole, we injected intravitreal SF6, and even without surgery, we could successfully close this macular hole. The second category is a medium macular hole. These usually require a surgery, but vitrectomy alone suffices. In this case of a medium macular hole, after removing central vitreous, we stained the posterior hyaloid with triamcinolone and then carefully induced a posterior vitreous detachment. Once all the vitreous had been removed, we closed the case with fluid gas exchange. Vitrectomy alone could successfully close this macular hole. The third and final category are those of large macular holes. In such cases, we need to do an ILM peeling along with the vitrectomy. Most surgeons nowadays prefer to do an ILM flap technique to handle large macular holes. After doing vitrectomy, we stain the ILM with brilliant blue dye, and then, as shown in the video here, we create an inverted modified ILM flap to cover the hole. Next, we do a fluid gas exchange, and with this vitrectomy plus modified ILM flap technique, even large macular holes can be successfully closed. However, there are occasions when the decision of how to treat a macular hole may not be so straightforward. So here is a case, a 72-year-old female who presented to us for routine checkup. On examination, we realized she had a pigment epithelial detachment in her left eye. We suggested periodic monitoring for her. She came back after 4 months with complaint of increased loss of vision in her left eye. On evaluation, we realized she had a full thickness macular hole along with the PED. Second patient, a known diabetic for 20 years, who presented to us with complaints of distorted vision. We did an angiography and OCT and realized he was suffering from proliferative diabetic retinopathy with diabetic macular edema. So, after initially treating him with anti-VEGF injections, we did pan-retinal photocoagulation. With this, we succeeded in stabilizing his eyes and he improved in vision. However, 3 years later, he came back with complaints of loss of vision in his left eye for 3 months. And we realized he had developed a full thickness macular hole in the setting of a post-PRP stable PDR. So now we have a case of a macular hole with PED and another of a macular hole with PDR. How do we manage such cases? Well, my message is one should not get distracted by these associated conditions, but like Arjuna, approach even these cases by evaluating the holes with the three criteria described before. So in the first patient, there was no obvious secondary cause of the hole formation. So this was a primary macular hole. There was vitreomacular separation, and OCT showed that the aperture size was more than 400 micron. So a primary macular hole of large size. So we did vitrectomy, stained the posterior hyaloid with tricot and induced a posterior vitreous detachment, and then after staining the ILM with brilliant blue dye, created a temporal modified inverted ILM flap to cover the hole and finished the case with fluid gas exchange. We could successfully close the hole with this vitrectomy ILM flap technique, and even the PED reduced in size. In the second case, as the diabetic retinopathy appeared stable, we presumed this was also a case of a primary macular hole with vitreomacular separation. And again, this on OCT had a aperture size more than 400 micron. So we again did a vitrectomy, induced posterior vitreous separation, stained the ILM with brilliant blue dye, and created an inverted ILM flap to cover the hole. At the end, a fluid gas exchange was done. Here too, the ILM flap technique along with vitrectomy succeeded in closing the macular hole. So our take-home message would be: how you approach a macular hole depends on the cause of the hole, the status of the vitreous, and aperture size. With proper planning, all holes can be successfully closed, irrespective of associated features. Or to put it simply, if there's a hole, there's a way.